So welcome back. The next topic is complications of cirrhosis. Fundamentally, what is cirrhosis of liver and what it can lead to? You know very well that the liver parenchyma, when it gets damaged, you call it as cirrhosis. What is the circulation of liver? There is a gut. From the gut what comes? Mesenteric vein. And here you have a spleen, and from spleen what comes? Splenic vein. Mesenteric and splenic vein combine to form portal vein, which goes and drains into liver. And the hepatic sinusoids will filter, extract whatever they want from the blood, right? And all the blood leaves it out. And where does it leave it out? Into hepatic vein. The hepatic vein in turn will drain into IVC. IVC goes to the right atrium. So this is a typical appearance. Whenever cirrhosis of liver is there, the drainage coming from the mesenteric and the splenic vein become obstructed, and that lead to a back pressure on the spleen, and that increased back pressure on the spleen will lead to splenomegaly, and that increased pressure inside the mesenteric veins will lead to exudation in the form of transudation in the form of ascites. So this is the typical problem that occur whenever there is any cirrhosis of liver. Now let us look into complications of cirrhosis. There is a portal hypertension. Portal vein develops hypertension, and because of that there is a splenomegaly, ascites, portal hypertensive gastropathy. What is the meaning of gastropathy? Splenic vein is there, no? This backward congestion which is occurring into splenic vein also has got a relationship with the circulation of the stomach. You go back to anatomy and check what is the blood supply of lesser curvature, greater curvature, everything. It has got a venous drainage that happens through splenic vein. So any congestion in the splenic vein in turn will have a congestion on stomach, and that's the reason there is a portal hypertensive gastropathy. Then you have systemic vessels coming from IVC, right? And portal venous collaterals. These two basically will have a anastomosis at the lower part of esophagus. Whenever increased pressure in the portal circulation is there, that reflects in the opening up of portosystemic anastomosis at the lower GI, and that lead to bleeding, and that's how it presents like a hematemesis. So that's how you have the typical gastroesophageal varices and hematemesis. So gastroesophageal varices, portal hypertensive gastropathy, splenomegaly, and ascites, they are all the consequences of portal hypertension. You also have hypersplenism. What is the meaning of hypersplenism? Whenever the spleen is the graveyard for RBCs, WBCs, platelets. Whenever massive spleen is there, all RBC, WBCs and platelet, all their count will come down, and patients will have pancytopenia because of that. That's called hypersplenic state. Then you have coagulopathy. Liver is the source for all the clotting factors. That's the reason. What are the clotting factors which are produced in the liver? 2, 7, 9, 10. So their deficiency will occur typically. And then bone disease. Why bone disease? Because liver is important for 25 hydroxy vitamin D production. 125 dihydroxy occur in kidney, but 25 occur in liver. That's the reason whenever vitamin D levels get lesser, typically you develop bone disease, osteopenia, osteoporosis, osteomalacia, etc., etc. Then patients will have hematological abnormalities. What are the hematological abnormalities? Typically, they will develop anemia, hemolysis, neutropenia, all because of hypersplenism. Right? Then they will also have hepatorenal syndrome. I'll talk about hepatorenal syndrome. Whenever liver cirrhosis, severe liver dysfunction is there, that leads to renal dysfunction. And renal dysfunction will lead to high urea and creatinine. Any urea creatinine rise that is happening because of the problem in the liver, but not the problem per se in the kidney, is what is that condition called? If the kidney failure is there, you have high urea creatinine. But kidney is not having a disease like glomerular nephritis or interstitial nephritis. But problem is there in the liver. Because the problem in the liver, whenever the kidney dysfunction in the form of urea creatinine elevation occur, then you call it as hepatorenal syndrome. Then you have hepatic encephalopathy. Why? Normally, what is the function of liver? Liver is the place where urea synthesis occurs. Ammonia become urea. If the liver is not functioning, ammonia remains ammonia, and high ammonia go to brain, and in the brain it lead to coma, which is called hepatic encephalopathy. Then hepatopulmonary syndrome, just like liver dysfunction lead to kidney, liver dysfunction also lead to lung dysfunction, which is called hepatopulmonary. And there can be malnutrition. So these are all the complications of cirrhosis. Simple. Is passing exams really difficult? No. That's how we reach at this point, right? So whenever there is a portal hypertension, liver insufficiency, that's how you can broadly divide the liver dysfunction. And all your ascites, they're all variceal hemorrhage or consequence of portal hypertension. And the liver insufficiency lead to jaundice, encephalopathy, etc., etc. So that's how it presents. So I'll leave the literature for you to discuss, but most important is what is meant by hepatorenal syndrome. Typically, whenever liver dysfunction is there is a rapid progressive reduction of the renal function, and the serum creatinine become almost doubled in less than 2 weeks, and that is basically called type 1 hepatorenal syndrome. Fundamentally, why hepatorenal syndrome basically occur in the patients? Whenever there is a advanced liver failure and there is a portal hypertension, whenever advanced liver failure with severe ascites with portal hypertension, what will happen? Why the kidney is failing? Because the liver has failed. What is the pathophysiology of hepatorenal syndrome? Whenever the liver is having severe dysfunction, it lead to portal hypertension, that lead to ascites. What is the meaning of ascites? With large fluid in the peritoneal cavity, the intravascular volume, what will happen? Typically decreases. Whenever intravascular volume decreases significantly, what is the nature of the kidney? Renin-angiotensin system get activated and it will release a lot of vasopressors, and those vasopressors in turn will cause significant vasoconstriction and further compromise the renal plasma flow, and that decreases the GFR, that will increase the creatinine. So who is the culprit? Significant release of vasopressors because of the decreased intravascular volume, because of the significant ascites, because of the significant liver disease, is ultimately causing the rise of urea creatinine, not because of any glomerular nephritis or a tubular interstitial pathology. So what is hepatorenal syndrome? Hepatorenal syndrome is a functionally reversible failure of the kidney as a consequence of significant production of the vasoconstrictive substances whenever there is a decreased intravascular volume because of significant portal hypertension due to liver disease. Is the underlying cause, is what you have to basically remember. Once more, in this there are two types of hepatorenal syndrome, type 1 and type 2. Type 1 present like an acute renal failure. Whereas type 2, renal failure is not that acute. It is only a moderate renal failure. Creatinine only elevates 1.5 to 2.5, not double. Normal creatinine is 1. More than 2.5 means significant elevation, right? That happens in type 1. But in type 2, moderate renal failure will be there. A progressive clinical course, not a rapid clinical course, and refractory ascites. However, you take out fluid, once more it starts filling like Kerala coconut water, right? That is basically called type 2 HRS. That is what you have to basically understand. So, doctor, complications of cirrhosis, not a very difficult thing. Then comes the thalassemia minor. Examiner didn't ask major. Tomorrow if major patient comes, what will you tell him? Sorry, I passed MBBS reading minor only. I don't know major. Your uveitis is right lie, but I studied left eye uveitis. Will you tell like that or what? So thalassemia minor. So what is the basically problem in thalassemia? Typically, there is a mutation in the production, the gene that lead to production of the chains of that constitute the globin part of the hemoglobin. Hemoglobin has got a heme part, globin part. So the globin has got 4 chains. What are the 4 chains that you have? 2 alpha, 2 beta, right? So if the production of the globin chain is abnormal, you get what is called thalassemia. Now once more, the gene that decides has got 2 alleles. One comes from Abba or one comes from Amma, right? If both the genes, both the alleles of the beta producing gene are abnormal, you get a homozygous decreased production of the beta chains. But if it is a heterozygous, one normal, one abnormal, then only one beta chain is basically absent. Such a single allelic mutation or the 2 alleles in a heterozygous state is basically called beta thalassemia minor, and in this there is a decrease in hemoglobin, there is a anisopoikilocytosis, there is a rise of bilirubin. What is the meaning of anisopoikilocytosis? It looks like Arabic, but what is the meaning of that? Whenever there is a anemia because of a low hemoglobin, bone marrow will start overproducing the RBCs. When the erythropoiesis is very rampant and it is overproducing, will bone marrow get time to properly create a biconcave disc shaped RBCs? No. जो भी तैयार हो गया फेंको like Chinese stalls will be there, no? Anything you buy 10 rupees. काम करे तो करेगा शाम तक, नहीं करे तो क्या है? अगर शाम तक काम करे तो जिंदगी तमाम काम करेगा, अगर नहीं काम करे तो शाम तक भी नहीं काम करेगा. So that is what happens with anisopoikilocytosis. It keeps producing small, big, chota, lambo, bada, motu, सबको तैयार करेगा. So such different shapes of RBC production is occurring in thalassemia because of bone marrow trying to compensate for abnormally hemoglobin and anemia. You get anisopoikilocytosis. Then if you do hemoglobin electrophoresis, typically you will have hemoglobin A2, hemoglobin A and hemoglobin F. Other than A, you also have F and A2, which are typically increased. And that is the problem in beta thalassemia minor. Minor patients are all asymptomatic. They'll have anemia, they'll have a microcytic anemia, they'll have elevated HbA2 levels. Elevated HbA2 levels. Then if you look at, by the way, what is the meaning of HbA2? वो भी बताओ फटाफट. Yeah? How many types of chains that you know? alpha, beta, gamma, theta. Theta is also there. Gover hemoglobin, so many types of hemoglobin are there. Unit review. So okay. Whenever beta is not properly produced, what will the body will do? It will produce more amount of gamma. So when alpha 2, gamma 2 is there, what type of hemoglobin you call? Fetal. That's the reason HbF levels typically become elevated whenever beta chain is abnormal. But in alpha thalassemia, there is anemia, but will HbF levels increase? No. Why? HbF is alpha to gamma 2. Adult hemoglobin is alpha to beta 2. Problem in alpha thalassemia is alpha is not produced. Alpha is required both for fetal and also for adult. So that is the reason. How do you differentiate alpha thalassemia and beta thalassemia whenever you do electrophoresis? Increased HbF with a decreased HbA is the nature of beta thalassemia. Decreased HbA but no increase of HbF is the feature of alpha thalassemia. That's how you basically differentiate. Okay, doctor? But what is the difference between beta thalassemia major and minor? Minor is the heterozygous state. That's the reason patients are asymptomatic, anemia is very minor, you get a microcytic anemia, etc. etc. Whereas in major, you get a severe anemia, severe intramedullary hemolysis, and where is the hemolysis occurring in? Spleen. So splenomegaly will be there. Whenever the spleen is looking at a abnormal beta thalassaemic chains in the RBC, it will get that feeling to eat it and swallow it. Right. So splenomegaly will be there, and patients will have skeletal abnormalities. Why skeletal abnormality? Whenever the bone marrow of the long bones is no more able to compensate anemia, the body will try to start using extramedullary sites like a calvarial bone, etc. They will also get into the job of doing hematopoiesis. They become thickened, right? So that is called skeletal abnormalities, and ultimately patient go due to anemia into congestive heart failure. Okay. So one point you have to remember, doctor, HbF increase is a feature of beta thalassemia, no such disproportionate increase in alpha thalassemia. Bus, more than enough. The next question is very unexpected question in MBBS exam. Treatment of aluminum phosphide poisoning with signs and symptoms whether January 2015. Too much question. Aluminum phosphide. I know what treatment you will write. Aluminum means, okay, let us write germanium is used as the treatment and something like that. So let's talk about it. Where do we use aluminum phosphide? We use it as a rodenticide to kill rats. What is the treatment of rat poisoning? Give cat poison. What is the treatment of rat poison? That's what he is asking. Right. So it is used as fumigant. Insecticide. I know how you pass MBBS exams very well. So aluminum phosphide is a rodenticide. If it is consumed, give catenticide. Cat poison. No. So Cellphos is a very common brand name of this aluminum phosphide which is used as a rat poison. So how does rat poison kill a human being if it is consumed? Typically aluminum phosphide liberates phosphine gas. Phosphine gas typically will inhibit cytochrome oxidase, and that typically lead to severe, where do you require cytochromes? Electron transport chain. If it gets blocked, then you will end up in anaerobic metabolism. Aerobic is no more possible. So patients will develop lactic acidosis and that will kill people. And 150 to 500 mg is the fatal dose. And how do they present, doctor? They will have GID manifestations, cardiovascular, nervous system, etc. etc. Then how do you diagnose basically? So basically on the history Always in every poisoning case, ask the villager, please bring what did your wife consume, right? And if you forget to ask that question, you will end up in a surprise, you know. I still remember there was a patient from the village, snake poisoning, snake bite. So seriously writing the case sheet, the lady is lying down and all initial first aid was done. So what actually has bitten your wife? We asked a question. Yes sir, yes sir. He is only saying yes sir. What yes sir? The moment you raise the head, he is holding the snake. He killed the snake, put it in the bag and then want to show you actually. So by the time I raised the head, he is holding the snake. I don't know its name, sir. You decide what is its name. But it is the one which bitten my wife. But my wife is more poisonous than her. That's the reason it has died. Okay. So be very sure while writing history, forensic history. Lot of times snakes are non-poisonous. People die out of fear due to weak mind. Lot of times we fail in exam not because of examiner, because of ourselves. So let's not do that. So phosphine, how do you diagnose it? Patient's breath will have garlic smell if it is aluminum phosphide poisoning. Two things you need to remember about the treatment of aluminum phosphide poisoning, doctor. Magnesium sulfate, eclampsia of pregnancy, we use MAC sulfate, Pritchard's regime it is called as. Don't worry, we will teach you nice obstetrics gynecology also. All 600 questions asked in the last 15 years. Calcium gluconate is the one which you need to give. Two antidotes, two things you have to remember. Why will you give? Actually, there is no direct antidote against the aluminum phosphide. But those who had aluminum phosphide toxicity, there is a very high chance of them dying because of cardiac arrhythmias, which occur due to hyperkalemia. To negate that, we give calcium gluconate. And we also give MAC sulfate. They are the two things which are basically administered. So that is the story called aluminum phosphide poisoning. The next major question is diabetic ketoacidosis. Clinical features, how do you clinically manage the decay? Recently only we discussed with some of the students, but once more we will repeat. Okay. Tell me the story of that DKA patient. 10 times you read also, no use, doctor. Go to emergency, casualty. Radha, Badha, Sunita, Anita, Kavita. So many patients will be there with DKA. Anjamma, Anjaya, Mallamma, Mallanna. All will be at least in a busy casualty, in a night duty, 1 or 2 DKA patients definitely will come. 10 times you read Davidson also, maza nahi hai. You go and stand on the side how your house surgeon or resident is managing. He is giving insulin, he is giving IV fluids, he is pushing potassium, he is giving bicarb, he is handling the acidosis and ketosis and replenishing the insulin. Unless you see one night, you won't forget. Will you do that for me? You have to do. Post dinner walking karna hai, casualty mein, then you will have one. Now, what's the problem in DKA? DKA typically occur whenever there is an absolute insulin deficiency. Whenever insulin is not there, insulin is a lipogenic hormone. If there is no insulin, there is a lipolysis which will occur. That will release free fatty acids. Okay? Free fatty acids are all broken down by beta oxidation into acetyl-CoA. Acetyl-CoA, 2 molecules combine to form acetyl-CoA, which is called ketone body. So what is the cause of the ketosis in case of insulin deficiency? Insulin is lipogenic hormone, lipolysis releases the free fatty acids, beta oxidation release acetyl-CoA, and all acetyl-CoA converts into acetone, acetoacetic acid and beta hydroxybutyric acid. How can you stop the ketosis? Only by replenishing insulin. Insulin. That's why then what is the crux of treatment of decay? Administration of insulin is what you need to remember. What is the clinical presentation of a decay patient? Bolus and bolus and bolus of vomiting. Because of all that explosive vomiting, he is completely dehydrated. So only giving insulin, is it enough? No. What do you need to give? IV fluid. 3 to 4 liters of IV fluid you need to give to overcome that dehydration. Unless patient has got congestive heart failure. If he has got congestive heart failure just because, sir, Murli Bhargava sir, आपने बोला, नमो गुरुजी बोल के आप 4 liters चढ़ाए तो patient मर जाएगा. Half work got done, remaining half you did. Be careful before giving IV fluids. Auscultate the lungs. If there is any crepitations, right? If you find any wheezes, which are the signs of pulmonary edema, you should always evaluate. Look at pedal edema. Look at elevated JVP. They are all the signs of CHF. And CHF patients, you have to be careful about giving fluids, is what you need to remember. So it is the insulin deficiency which typically lead to hyperglycemia and ketogenesis that lead to acidosis, and hyperglycemia lead to osmotic diuresis. Every time high glucose is passing through kidney, it will carry it with it tons and tons of water out. That is another cause of dehydration. One is vomiting, other is osmotic diuresis. Along with the water, it will also lead to electrolyte imbalance. So these are all the problems in case of decay. So what is the etiology of decay? Patients who are regularly taking insulin, type 1 diabetics, sometimes they will miss to take because second year exam is there, third year exam is there, or sometimes they may feel why to take insulin every day. These are all the challenges of real life, doctor, let me tell you. So insulin missed dose, pancreatitis, or if they take a heavy meal but a very low insulin, that also can end them in decay. Then sometimes body may produce excessive counter-regulatory hormones. Who are the opposition party to insulin? Growth hormone, adrenaline, etc. Right? So whenever patient has got a myocardial infarction or infection or stroke or trauma or emotional problems or pregnancy or iatrogenically, in all these scenarios, the epinephrine levels in the body, if they are excessively produced, the insulin, though you are taking the same regular 10 units, if infection is there, that release more epinephrine in the body, and this 10 units insulin is no more adequate, and that lead to development of ketosis. So that is the reason any time whenever a DKA patient comes, diabetic ketoacidosis or a hyperglycemia with ketone bodies, whenever patient comes, look whether there is any precipitating factor. What is the precipitating factor? Infection. Infection can be pneumonia, infection can be UTI, infection can be sepsis, and look whether there is any intercurrent illness, like is there any MI? A lot of times MI patients we don't check the decay. We only will be focusing on MI. Don't do that. MI patients, stroke patients, if they are already diabetic patients on insulin, always check their sugar levels while same time managing their stroke and MI. That is a very important rule. There is another entity called hyperglycemic hyperosmolar non-ketotic coma. It is also a hyperglycemic state like decay, but there is no ketone body production, but only significant hyperglycemia only will be there. It is more common in the people who have type 2 diabetes, whereas type 1 diabetics have more likelihood of decay. Then glucose levels in hyperosmolar coma will be more than 600, such a significant level. What is the normal sugar? Random sugar is supposed to be less than 180, fasting sugar less than 125. In case of pregnant women, less than 100, above 100 of fasting sugar is considered to be uncontrolled diabetes. In pregnant women, what is the postprandial sugar expected to be? Less than 120, not 180. Pregnant women, don't forget. Then ketonuria will be more in decay acidosis is more profound and significant in DKA. Osmolarity will be significantly hyperosmolar because high sugars, more than 600, significant hyperosmolarity will be there. And even small dose of insulin you give also, this become normalized. Whereas here you have to give significant amount of insulin to treat DKA. DKA versus HHA, hyperosmolar, non-ketotic, hyperglycemic coma. Differences between the two is a favorite question of the examiner. Okay, doc. Now, how do you clinically, now what is the diagnostic criteria to call DKA? You must be very sure. Now, one, blood glucose more than 250. You don't call DKA just because ketones are positive with a blood sugar 220. It should be more than 250. Patient should have dehydration features, mild to moderate. Ketonuria in the urine will be positive. Serum bicarb is less than 15. What is the normal serum bicarb, doctor? Very simple to remember. 3 values, don't forget, doctor, as a good undergraduate student. Partial pressure of oxygen, partial pressure of carbon dioxide and serum bicarbonate. You should never forget this. And serum sodium and serum potassium. Why? These 5 values. If you don't remember, patient will die and everybody will remember him once in a year. Right? So you have to remember. Please remember. Right? If you don't remember, electrolytes are the rats that roar like lions if you don't handle them properly and lead to mortality. That's the reason you should. PO2, partial pressure of oxygen, right, is typically in the room air is considered to be between 70 to 80 millimeters of mercury. Partial pressure of the carbon dioxide is supposed to be less than 30. Bicarbonate is nearer to 20 to 25. And serum sodium around 130 to 135. Potassium 3.5 to 5.5. These values, like a parrot, you must remember it anywhere you go, because this is what you will manage patients, otherwise they will die. Any PO2 less than 60, you call significant hypoxia. Any PCO2 more than 40. Okay, you can just close this door. Close the door. Yeah. Any PCO2 more than 40, you call it as hypercarbia. Sai, please be with the can. Bicarbonate, anything less than 15 is considered to be low bicarb, and serum sodium anything less than 130 and any serum potassium less than 3 is hypokalemia. More than 5 is considered to be hyperkalemia, more than 5.5 or 5, right? So these are the values you should remember. So serum bicarb less than 15 is considered to be abnormal. pH is acidic, that is arterial less than 7.3 or venous blood sample height less than 7.25. This is the criteria to define diabetic ketoacidosis. Now what complications occur if you don't properly handle DKA, diabetic ketoacidosis? Number 1, the patient can go into respiratory distress syndrome. There can be elderly people, thromboembolism can occur if the acidosis is not properly handled. Then patients can develop significant hypokalemia in DKA, and that can lead to cardiac arrhythmias, respiratory muscle weakness and kill. Now you will tell, sir, why should DKA should lead to development of hypokalemia? You got the doubt or okay, anyway, list bol rahe na, bolne do, soch rahe kya? What is the role of insulin in the potassium's life? Potassium is principal Intra or extracellular? Intracellular. The role of insulin and the role of epinephrine is to push the potassium into the cell. If there is no insulin, potassium does not remain in the cell and it will come out of the cell. Okay. Then in DKA there is lot of vomiting and there is a lot of dehydration. Whenever you have vomiting, dehydration, what will it lead to? Plasma volume. What will it lead to? Renal plasma flow decrease. Whenever renal plasma flow decreases, who gets stimulated in the kidney? Renin-angiotensin. Whenever renin-angiotensin stimulated, who is produced? Aldosterone. What is the role of the aldosterone on the renal tubule? It leads to retention of sodium but loss of potassium into urine. So DKA lead to dehydration and vomiting, decrease plasma volume, decrease renal plasma flow, decrease stimulate renin-angiotensin, increase aldosterone, aldosterone lead to caliuresis, caliuresis lead to loss of potassium into urine and that lead to hypokalemia. But what is the role of potassium, insulin on the cell? Its role is to move the potassium intracellular, right? But if insulin is not there, what will happen to the potassium? It remains extracellular. The plasma which you are collecting is extracellular fluid or intracellular? Extracellular. So what will happen in insulin deficiency is a paradoxical situation will happen. If you take the total body potassium of the person, it is low. But all that potassium is remaining in the extracellular fluid in the plasma. That's the reason when the patient arrives, if you happen to take the blood sample, his serum potassium levels will be normal. But the moment you start insulin therapy, what will happen? That low potassium runs inside the cell and the patient will end up in significant hypokalemia. So that is the reason. What is the rule in a case of a DKA patient? The moment he arrives, check his serum potassium. If the serum potassium is already low, then you initiate potassium infusion. Suppose if it is not low, don't think it is not low. You check it after giving insulin therapy after a couple of hours. And if the potassium at that time is low, then you initiate the potassium therapy. Now tell me a condition. Patient has got a DKA, he came to the hospital, but when you checked potassium, instead of hypokalemia, he is having hyperkalemia. Can it happen? Definitely. Suppose if the patient is having chronic kidney disease, diabetes lead to diabetic nephropathy and chronic kidney disease. So if he has a chronic kidney disease lead to hyperkalemia, and chronic kidney disease due to diabetes, and that diabetic patient has got diabetic ketoacidosis, right? So in spite of diabetic ketoacidosis, you may discover in a chronic kidney disease patient sometimes hyperkalemia. So tell me, a DKA patient, can he have hyperkalemia? Yes. When will he have hyperkalemia? Whenever he has got an underlying single long answer, chronic kidney disease due to diabetes. When he can have hypokalemia? When the vomiting, dehydration is so significant that he had significant caliuresis and totally he is into hypokalemia. Third situation, can he have normokalemia? He can have. Why? Because though the total body potassium is low, since insulin is required to move the potassium intracellular, insulin deficiency keeps even that low potassium extracellular. If you take out the plasma, it may look like a normokalemia, but the moment you start insulin therapy, he will end up in hypokalemia. So that is all about the potassium management in a diabetic ketoacidosis patient. Then diabetic ketoacidosis patients not only will have hyperglycemia, they can also end up in hypoglycemia. Then they can land in pulmonary edema. Suppose if you happen to over-treat a patient of DKA, they may develop overhydration and pulmonary edema. Then very important complication of decay is they can develop cerebral edema, especially pediatric patients with decay. What is the common age group where type 1 diabetes will present itself? 8th class, 9th class, 10th class is the time where a juvenile patient, sweet teens, will first time present with type 1 diabetes, and that presentation will be like decay. Pediatric patients decay, they are more vulnerable to develop cerebral edema. That's the reason you have to take care. So how do you manage? What are the three things that you have to take care? Potassium replacement, insulin replacement, and first is always fluid replacement. So how much fluid you have to give? Generally, the fluid of choice in decay is normal saline. 0.9% saline is called normal. You will give 1 liter in 30 minutes, 1 liter in 1 hour, 1 liter in 2 hours, 1 liter over the next 2 to 4 hours. Totally 4 liters should run, unless patient has got a congestive heart failure. Then a very important thing, will you only give normal saline or any other fluid? The other fluids that you know are ringer lactate and dextrose. Only 3 fluids, normal saline, ringer lactate or 5% dextrose. There is a hypertonic saline called 3% saline, 3% sodium chloride. There is one more half normal saline, 0.45% saline. There is hypertonic glucose solution, means what? Instead of 5%, if you give 10% or 20% glucose, then you call it as hypertonic glucose. Okay. So commonly what we use is only 3: normal saline, ringer lactate, or 5% dextrose. So what is the general rule? Initially you give normal saline whenever the blood glucose is more than 270. Once it becomes less than 270, because your insulin drip will be running, because of that sugars from 300, 350 they keep coming, and once the moment they come below 270, that time you introduce 5% dextrose, 5% dextrose, and that's how you typically do. Now, what is the dosage of insulin you need to give? What type of insulin you will give? Insulin may be बहुत types hai. We will give you username password of anatomy2medicine.com. Any pharmacology you have not read or anything that you have doubt, we have all 19 subjects in MBBS, both theory, MCQ discussion available in the online video library. Any doubt you get, you go to pharmacology, you open insulin, there is a video discussion, types of insulin, etc., etc. Just review the video. You can do it even on the mobile, right? So, normal insulin, regular insulin means crystalline insulin. They both are the same names, regular insulin. Then you have different types: protamine, zinc insulin, lenti insulin, ultra lenti insulin. So many types are there. But the type of insulin that we give in decay is regular insulin. Common rule is what? The moment the patient walks in, 15 adult patients, 15 units of insulin you will give intravenously, right? Then 50 units of insulin you will add it into a normal saline and run the drip at 50 microdrops per minute. Tell me, 15 units of regular insulin you will push IV, add 50 units into the normal saline and run it 50 microdrops, and then keep monitoring the glucose levels hourly, right? And according to the glucose levels, you either speed up or slow down the drip. So this is how you will maintain a chart: blood glucose level, insulin infusion, and dextrose, 5% dextrose. Whenever the insulin is more than 500 or more than 400 or more than 300, are you giving 5% dextrose? You are not giving. The moment it is between 251 to 300, that means less than 270, that time you will initiate 5% dextrose. Okay. Then how do you run the insulin infusion, doctor? Basically, typically more than 500 you run 20 units per hour. 450 to 500 you run 15 units per hour. Like that you keep altering the insulin infusion. Don't worry, you need not write all this in the exam. I know what you are thinking in your mind. Sir, ये सब लिखना, सब याद रखना? No, no, no. Examiner will look at 4 words. Treatment of decay. First, did you write IV fluids? 4 liters. 1 liter when, 1 liter when, 3rd liter when, 4th liter when. Did you write or not? Second, did you talk about insulin? That too, if you say 50 units of insulin in one shot and 15 and 50 units added to normal saline bottle and runs at 50 microdrops per minute, oh kush, अगर ये टेबल में डाल दिए तो मर जाते लिखते, आपका पेपर करेक्शन करते हुए you'll have a MI. ओरे बाप, इतना मालूम है क्या आजकल बच्चों को बोल के? Third, potassium. If you say potassium, so what is the way by which potassium is replenished? When the patient arrives, check he has got hyperkalemia. If hyperkalemia is there, no treatment. If normal level, then also don't immediately give. Then you will check after 2 hours of insulin drip, and you will add 26 millimoles into 1 liter and then slowly infuse it. If hypokalemia is there, then also you don't give immediately in the first 1 hour. Never in the first 1 hour you will give, right? Then you will add 39 millimoles into 1 liter and run it. So this is how potassium is replaced. Then patients will also have phosphate deficit. That's the reason always you have to give potassium in the form of potassium phosphate is the form in which you give. Then bicarbonates. Just because acidosis is there, you won't jump and give bicarbonate in case of decay. Unless the pH of the blood is as low as less than 7, then there is an indication for bicarbonate infusion. So that is the points you need to basically deliver in tomorrow's exam. So tell me about decay. What are the main points to remember about decay? Pathophysiology. Why decay is causing ketone production and acidosis. Number 2, what are precipitating factors for the decay? Underlying infection, MI, stroke, etc., etc. The difference between decay versus hypertonic hyperosmolar coma. 4th, definition of decay. 5th is treatment. Insulin, bicarbonate, fluids, insulin, potassium, bicarbonate, whether to give or not, or when to give. That's what you need to ultimately represent. You still have energy? 8 o'clock. 16 questions we do, we are done with one paper. If you have energy, I will finish the remaining 6 questions. Fatapat. How many don't have? Raise the hand. Come on, doctor. Have or don't have? 6 questions. Fatapat khatam karenge. Irritable bowel syndrome. Anyway, examiner is also not expecting too much knowledge. Short questions, no. We'll give short answers. What is irritable bowel syndrome? There is no cancer in the bowel. There is no inflammation in the bowel. There is no infection in the bowel. But the patient has got a irregularity of bowel. That is called irritable bowel syndrome. What type of irregularity bowel can have? Either constipation or diarrhea. So if you have an alternating constipation and diarrhea without any organic lesion inside the bowel, just because your brain wants to go to the toilet, it is called irritable bowel syndrome. Simple. ऐसे भी लोग होते क्या? होते हैं. Any altered gut reactivity. Some people have hypersensitive gut. So the chai peete hi they will run to bathroom. So hypersensitive gut. Then brain and gut are closely related. When the person wants defecate, he can defecate. If he is psychologically depressed, he will get constipated. If he is stressed out about exam, he will have diarrhea. So brain and gut are actually continuity, right? So any problem in that brain-gut axis dysregulation lead to irritable bowel syndrome. How do they present? Patient will tell, doctor, every day this abdominal pain, doctor. I don't know, morning to evening abdominal pain. Chronic abdominal pain, discomfort, bloating, gas, doctor, gas. I'm bloating like a balloon, doctor. No, I don't want to eat because I'm afraid that I will be like a balloon. Go away. Then incomplete evacuation. He goes to stool and once more comes and thinks, did I not properly go to the stool? still that fullness in the gut will be there in the rectum. So that feeling will be there. And suppose if he goes and tries to move a little stool out of his body, the bowel movement will bring that symptomatic relief. And he will also have esophageal reflux and all these features without any organic cause. Then you call irritable bowel syndrome. So to call irritable bowel syndrome, there are certain diagnostic criteria called Rome 2 diagnostic criteria. What are they? At least 3 days per month in the last 3 months feature should be there to call irritable bowel syndrome. What features? Abdominal pain or discomfort relieved by defecation and the change in the frequency of going to stool and abnormal stool frequency should be there. When do you call? Less than 3 stools in a week, you define it as a constipation. More than 3 stools in one day, then you call diarrhea. So that's how you define abnormal stool frequency. Sometimes a hard stool, sometimes a loose stool. Similarly, urgency, straining, tenesmus, passage of mucus, etc., etc. They are all the other symptoms under the Rome 2 diagnostic criteria. The word Rome 2 you write, examiner happy in the irritable bowel syndrome, right? I know what you will write without preparation if you go to the exam. Still you will write irritable bowel syndrome is because of irritation. Because the problems occur in the bowel, there are some bowel symptoms. Okay, what are the bowel symptoms? Constipation and diarrhea. You write like that only, but little Rome 2 idhar udhar laga ke love letter likhna. So, what are the warning symptoms? If they are there, don't consider irritable bowel syndrome. Old age. अगर ओल्ड एज में किसी को कॉन्स्टिपेशन है तो यू हैव टू डू डिजिटल रेक्टल एग्जामिनेशन, कोलोनोस्कोपी, स्क्रीनिंग एंड आइडेंटिफाई एनी कोलन कैंसर. You only say no, it is only irritable bowel syndrome, then that's wrong. Blood in stool, patient is saying, sir, melena is there, blood tarry stool is there, smelling stool is there, sir. No, it is only irritable bowel syndrome. If you say, you are missing colon cancer. If the pain is very severe, with intestinal obstruction, if the patient is gyrating on the floor, you say, no, it is all irritable. Too much irritation he is having, if you say, that is wrong. Similarly, if there is any fever, never it is irritable bowel syndrome. Vomitings, if they are there, just not diarrhea, constipation, there is some obstruction, it is not irritable bowel. Similarly, dehydration, weight loss, anemia, acute presentation, any of these are all called warning symptoms. You have to rule out. So, do you want to investigate if you are clinically sure that it is irritable bowel syndrome? Generally, it is required only if warning symptoms and signs are there, then only you have to basically do. So, how do you basically treat them? Education, reassurance, yoga, pranayama, that's, homeopathy, yoga, all these, what are the main conditions that they are surviving, doctor, those branches? Constipation is one area, big area in homeopathy. Psoriasis, big area in homeopathy. Right? I still remember a Director General of Police, ferocious man, but ultimately last 5 years of his life, I remember, he used to say, doctor, tomorrow morning will I have the, what is that movie? Amitabh Bachchan ka? Piku. Huh? Piku, huh? What is that? Piku. It is based on the story of what happens in the old age, however powerful you are. So you have to give antispasmodics for the pain, and for constipation you can use rarely laxatives, and for the diarrhea you can give loperamide-like agents, but not that frequently. Psychotherapy is most important, and if depression is coming because of the bad bowel, you have to even give antidepressants. That's considered to be the treatment. Then quickly talk about hemodialysis. Why do we do hemodialysis? If there is a chronic kidney disease and renal failure, to get rid of the NPN, non-protein nitrogenous substances, urea, creatinine out of the body, we do dialysis, renal replacement therapy. What are the types of dialysis that you know? Peritoneal dialysis, hemodialysis, hemofiltration, they are all the ways. Two things only you know, doctor, complications, indications of hemodialysis. We'll quickly talk and get out of this topic. So how do you do hemodialysis? The patient's blood is passed through hemodialysis machine, filtration will be done like glomerulus is doing, and you are reperfusing the blood back into him, right? That is how you do. So if you look at the chronic kidney disease, it is being divided into stage 1, 2, 3, 4, 5. So typically the stage 4 is defined when the glomerular filtration rate is less than 30. That is the important indication where you have to prepare the patient. See, your kidney function is slowly deteriorating. You must also be prepared to start going for a renal replacement therapy. You should start counseling. The moment the GFR falls less than 10, then there is no waiting. That is called stage 5 CKD. Is the time where you have to plan to initiate the dialysis is what need to be remembered. So, what are the scenarios that prompt you to go for doing a hemodialysis? Suppose a patient of chronic kidney disease is having hyperkalemia. What is the treatment of hyperkalemia? Whenever hyperkalemia is there, first thing you have to do is you have to give calcium gluconate, because hyperkalemia lead to cardiac arrhythmias and patient may die because of cardiac arrhythmias. So first thing is calcium gluconate. Second, you will give insulin. Insulin moves the potassium intracellularly. So hyperkalemia will be used. But if you only give insulin, patient will die due to hypoglycemia. So you have to give insulin plus glucose. Third, what will you do? If it is still refractory, then hemodialysis. And long run, how do you treat hyperkalemia? You will give oral potassium binding resins, which will prevent the absorption of the potassium from the gut. 4 things for treatment of hyperkalemia. What are they? Acutely, calcium gluconate, insulin plus glucose. Third is hemodialysis. Fourth is potassium binding resins orally, chronic management. Similarly, chronic kidney disease patients, when they have metabolic acidosis, significant hyperphosphatemia, hypercalcemia, severe anemia, neurological dysfunction, pleuritis, there are some complications of chronic kidney disease which are reversible by dialysis, some which are not reversible by dialysis. So these are all the conditions where they are all reversible by doing the dialysis. That's the reason they are the indications of dialysis. How do you do dialysis? You have to take out the blood out of the body, run through the filter and push it back. You can do that by a venous access from the vein. You can do by creating a shunt, and you can also create a arteriovenous fistula or a arteriovenous graft and then take out the blood and then perfuse the blood back. That's what has to be done. Okay. So I'll leave the literature for you quickly on how the AV graft and AV shunts are done, but really examiner is not interested about all that. What is examiner is interested is what are the complications that can occur while you are doing a hemodialysis. What are you doing during hemodialysis? You are taking a lot of blood pushing through the machine. That machine can have hepatitis C. Filters may have HIV. And when the blood is going out and coming in, chances of infection are high. So infection is a problem. Number 2, when you are taking all the blood out of the body, then what prevents you to going into hypotension? Your autonomic nervous system should do. But if I am a diabetic with chronic kidney disease, I will have autonomic neuropathy. Then my autonomic nervous system may not immediately react. And what will happen? I may suddenly end up in hypotension. So there is a reason. There is what is called dialysis disequilibrium syndrome. The moment patient is undergone dialysis, he will suddenly feel the entire world rotating. He will be shouting. That's called dialysis disequilibrium syndrome. There can be muscle cramps due to dyslipidemias. There can be significant hypotension. The most common complication of hemodialysis that you have to take care is hypotension. Then arrhythmias, cardiac arrest, hypoglycemia, hemorrhage, infectious complications, anything can be the complications of the hemodialysis is what you need to remember. Question number 12 is pheochromosis. This is a big topic. Thoda we have to look at front and back of it and come. So we'll do it tomorrow, right? So 815. So what is our ultimate goal? 600 topics. Last 15 years of NTR, UHS. NTR will be happy in the heaven. Oh, so nicely final MBBS students are preparing, so knowledgeably they are going to exam, and ultimately all this knowledge will once more reflect tomorrow entrance also the same story but more specific story, right? This is a little non-specific story, but overall understanding you should have and confidence to write exam. That's the idea. Okay. So thanks for the patient listening. We'll catch up tomorrow.